Welcome to the Health Headliner podcast by Tudu Digital. Our content is informational only and not medical advice. Please consult your provider. Now, let's dive into today's headlines.
Okay, let's unpack this. We're talking about nearly 1.5 million people worldwide diagnosed with prostate cancer this year alone.
Wow.
Yeah, and almost 300,000 of those right here in the United States. I mean, those numbers are staggering. And it feels even more immediate with the recent news about former President Joe Biden.
Right, diagnosed at 82 with an aggressive form, and it spread to his bones.
Exactly. And what really stood out in the reports was that he sought help because of worsening urinary symptoms.
Yeah.
It makes you think, listening to your body likely made a huge difference in catching it when he did.
It absolutely does. And, a case like this, it really shines a light on metastatic prostate cancer. That's when the cancer spreads beyond the prostate itself. So today we're diving into that, using the news about President Biden as sort of a real-world anchor, but mostly drawing from a very thorough scientific review on current treatments.
So the goal is to get past the headlines.
Precisely. To give you, the listener, a clearer understanding of this complex disease, how it progresses, what the treatment landscape looks like right now based on the research.
Okay, so setting the stage then.
Yeah.
What does this scientific review tell us about just how significant prostate cancer is overall?
Well, it really emphasizes it's a major health issue. It's actually the second leading cause of cancer death for men in the U.S.
Second. Wow.
Yeah, and there's this huge contrast in survival rates. If it's caught early, localized prostate cancer, the 5-year survival is over 99%. Really encouraging.
That's great.
But if it metastasizes, spreads, like in President Biden's case, that 5-year survival rate drops dramatically, down to around 30%.
30? That's quite a drop, isn't it?
It is, and it just underscores why understanding how it's diagnosed early on is so crucial.
Okay, so let's get into that initial detection. What's the typical process doctors follow, according to the review?
It often starts with a blood test for something called prostate-specific antigen, or PSA. There's a bit of debate on when to start screening, generally somewhere between 40 and 55.
Okay.
If that PSA level is high, usually over 4 nanograms per milliliter, that's a flag. It means more investigation is needed.
And that often involves a physical exam too, right?
Yes, the digital rectal exam, or DRE. The doctor physically checks the prostate gland. It's about walnut size, just below the bladder for any lumps or hard areas.
Simple, but can be effective.
It can. The review also mentions genetic testing becoming more important.
Germline testing. What's the purpose there?
So germline testing looks for inherited gene changes linked to cancer risk. The review mentions genes like phosphatase and tensin homolog, tumor protein P53, and the breast cancer susceptibility genes BRCA1 and BRCA2.
Okay.
Finding these can help figure out someone's risk, and if cancer is found, it can sometimes help guide treatment choices, make them more personalized. But the definitive diagnosis really comes down to a biopsy.
Right, the biopsy. And that leads to the Gleason score, which we heard about with President Biden. Can you break that down for us? What does that score actually tell us?
Absolutely. The Gleason score is all about grading how aggressive the cancer looks under a microscope. A pathologist examines tissue from 2 different areas where the cancer is most prominent.
2 areas, okay.
Each area gets a grade from 1 to 5. 5 means the cells look very abnormal, very different from healthy prostate cells. Then you add those 2 grades together for the final Gleason score, which runs from 6 to 10.
So lower is better.
Generally, yes. A score of 6 is low grade, 7 is intermediate, and 8, 9, or 10 is considered high grade, meaning more aggressive cancer.
And the order matters, I read. Like a 4+3 versus a 3+4.
Exactly. The review points that out too. The first number reflects the most common pattern seen. So a Gleason 7 that's a 4+3 is typically more aggressive than a 3+4 because the dominant pattern is the higher grade 4. President Biden's score was 9, which confirms it's a very aggressive type.
That really clarifies things. Now, the review also mentioned different histological classifications. What does that refer to?
That's about the type of cell where the cancer started. The main ones for prostate cancer are epithelial cells, which line the glands, and neuroendocrine cells.
Okay.
Most prostate cancers, the vast majority, are adenocarcinomas. They start in those gland cells, the epithelial ones. But, and this is important, sometimes these adenocarcinoma cells can actually transform into neuroendocrine prostate cancer cells.
They can change type.
Sort of, yeah.
Yeah.
It's a process. The review differentiates between neuroendocrine cancer that's there from the start, they call that de novo, and the kind that develops later, often after hormone therapy. It's called treatment-emergent neuroendocrine prostate cancer.
And is that type worse?
Neuroendocrine types, especially the small cell subtype, tend to be very aggressive and harder to treat than the common adenocarcinoma. There's also a large cell subtype.
Okay. And to figure out if it's spread, that's where imaging comes in.
Exactly. Imaging is key. Computed tomography scans, CT scans, give cross-sectional pictures, good for checking lymph nodes or organs. Magnetic resonance imaging, MRI, gives really detailed views of the prostate itself and nearby tissues, helps guide biopsies, and checks for recurrence after treatment.
What about PT scans?
Positron emission tomography, or PT scans, often combined with CT or MRI, show metabolic activity. Cancer cells are often more active, so they light up. And there's a specialized one, the prostate-specific membrane antigen PET scan, or PSMA PET. It targets a protein found at high levels on prostate cancer cells, so it's very sensitive for detecting spread, even small amounts, and also for finding cancer that's come back.
So let's say cancer is found, but it hasn't spread yet. It's localized. What are the options then? The review mentioned risk categories.
Right. For localized cancer, doctors assess the risk low, intermediate, or high based on that Gleason score we talked about, the PSO level, and sometimes other factors.
And the treatment depends on that risk level.
It does. For low risk and even some intermediate risk cases, active surveillance might be an option. That means closely monitoring regular PSA tests, exams, maybe repeat MRIs or biopsies, but holding off on immediate treatment. The idea is to avoid side effects if the cancer is slow growing.
Makes sense. But for higher risk?
For higher risk, or if surveillance isn't preferred, the main options are radiotherapy, using radiation to kill cancer cells, sometimes with hormone therapy added, or radical prostatectomy, which is surgery to remove the entire prostate gland.
And surgery can be curative.
It can be, yes. That high survival rate for localized cancer often involves these treatments. But sometimes, even after surgery, the PSA level can start to rise again. That's called biochemical recurrence.
What happens then?
In that situation, what's called salvage radiotherapy might be recommended to target any remaining cancer cells.
Okay. Now the review moves into more complex territory. Non-metastatic castration-resistant prostate cancer. Can you break that down?
Sure. It sounds complicated, but basically non-metastatic means scans haven't detected spread to distant sites yet. Castration-resistant means the cancer is progressing, shown by rising PSA levels, even though the patient is receiving androgen deprivation therapy. That's hormone therapy meant to drastically lower testosterone, which usually fuels prostate cancer growth.
So the standard hormone therapy isn't working anymore, but it hasn't spread visibly on scans.
Exactly. Treatment then usually involves intensifying that hormone blockade, often adding newer drugs called androgen receptor signaling inhibitors, things like enzalutamide, darolutamide, or apalutamide.
Is this a dangerous stage?
It's a point of concern because the review highlights that a significant portion of men in this stage do develop detectable metastases within about 2 years. So close monitoring is key.
And what if the cancer is already spread right at the initial diagnosis, like President Biden's situation?
That's called newly diagnosed metastatic prostate cancer. If imaging, often that sensitive PSMA PET scan, shows spread to bones or other organs right from the start, then surgery to remove the prostate usually isn't the first step.
So what is?
Treatment becomes systemic, meaning it treats the whole body. It typically involves combinations tailored to the individual, definitely androgen deprivation therapy, often, plus those androgen receptor signaling inhibitors, maybe chemotherapy like docetaxel, or sometimes targeted radiotherapy to specific spots.
Okay. The review also mentions metastatic castration-sensitive prostate cancer. How's that different from castration-resistant?
The key word is sensitive. It means the cancer has spread, it's metastatic, but it is still responding to the standard androgen deprivation therapy. Lowering testosterone is still effectively slowing it down.
So hormone therapy is still the main approach.
Yes, androgen deprivation therapy is the backbone, using drugs called luteinizing, hormone-releasing hormone agonists or antagonists. But often, especially now, doctors add other treatments right away to improve outcomes.
Like what?
Things like those androgen receptor signaling inhibitors. The review mentions abiraterone acetate, enzalutamide, apalutamide, also potentially bone-strengthening drugs if it's in the bones, certain radioactive drugs, or even PRP inhibitors if specific gene mutations are present.
Lots of potential combinations.
Yes, but the review makes a crucial point. Eventually, most cancers in this stage develop resistance to the hormone therapy.
Which leads us back to metastatic castration-resistant prostate cancer, or mCRPC. That sounds like the really challenging stage.
It definitely is a more difficult phase, that cancer is growing and spreading despite testosterone levels being kept very low.
So what are the options then?
The options broaden, but the choices depend heavily on previous treatments, the patient's health, and specifics of the cancer. You might see second-generation versions of those hormone drugs, like abiraterone or enzalutamide again, or different chemotherapy drugs like docetaxel or cabazitaxel.
Are there other types of treatments too?
Yes, there's an immune-stimulating therapy called Sipuleucel T, immune checkpoint blockers like pembrolizumab in certain cases, those PARP inhibitors like olaparib or rucaparib, especially for men with BRCA or similar mutations, plus drugs specifically targeting bone health, a radioactive drug called radium-223 dichloride, and another targeted radioactive therapy, lutetium-177 PSMA 617.
Wow, quite a list. It seems very complex.
It really is. And then the review specifically discusses metastatic neuroendocrine prostate cancer, why the special focus there.
Yeah, what's different about that one?
It's a particularly aggressive subtype. The review explains this idea of lineage reprogramming, where the typical adenocarcinoma cells, which need hormones, can sort of transform into these neuroendocrine-like cells that often don't need hormones.
So they change to resist the treatment.
That seems to be a key mechanism of resistance, yes. And as we mentioned, it can either be there from the start or develop later after treatment. The big problem is that the standard prostate cancer treatments are often much less effective against this neuroendocrine type.
Okay, so let's connect this back to former President Biden's situation. His oncologist mentioned his cancer is sensitive to hormones, but has spread to the bones. Where does that fit?
Based on that description, it sounds like his cancer would initially fall under that metastatic castration-sensitive category we discussed, with bone involvement.
Right, sensitive to hormones.
Yes. So, as the oncologist indicated, starting with hormone therapy, androgen deprivation therapy makes sense as a primary approach. And given the bone spread, combining it with chemotherapy and specific bone-targeting drugs to manage pain and prevent fractures would be a likely strategy.
It really drives home the seriousness when you hear that stat 1 in 8 men diagnosed in their lifetime. The news reports emphasize that, while it's often not life-threatening for many, President Biden's aggressive case shows just how serious it can be.
That's such a critical point. And the report also stressed something vital. Early prostate cancer often has no symptoms, zero.
Which is why screening is pushed. Right.
Exactly. That PSA test, the digital rectal exam, they become so important, especially for older men or those with a family history. Symptoms usually only appear when it's more advanced.
What kind of symptoms?
Things like urinating more often, difficulty starting or stopping urination, pain in the pelvis, hips or back, persistent fatigue, losing weight without trying. Essentially the kind of symptoms that, thankfully, prompted President Biden to seek help.
Okay. Now, the scientific review you mentioned, it seems to spend quite a bit of time on clinical trials for these advanced forms, especially that neuroendocrine type. What are some of the roadblocks or limitations they highlight in the research?
Yeah, the review is quite candid about the challenges. One big issue is simply the number of trials specifically for neuroendocrine prostate cancer. There just aren't that many, which makes it hard to draw really strong conclusions.
Fewer patients, less data.
Pretty much. Another tricky area is interpreting side effects reported in trials. It's not always easy to tell if an adverse event is definitely due to the drug being tested, or if it's related to the underlying cancer, or how severe it actually is for the individual.
And the way the studies themselves are set up can matter too.
Definitely. The review points out inconsistencies in how trials are designed, plus factors like, who funds the research, potential influence from drug companies, how much different research groups collaborate, all these can impact progress.
Okay.
There's also the issue that the people in the trials might not perfectly match the general patient population who will eventually get the drug, which can affect how well the results apply in the real world.
Right, the real-world evidence gap.
Exactly. And even what the new treatment is compared against in a trial, the control arm can influence how good the new therapy looks. And finally, a huge issue the review touches on is cost. Many of these newer therapies are incredibly expensive, raising serious questions about accessibility for everyone who might benefit.
So despite those challenges, what were some of the key findings or expert takes from the review on potential treatments? particularly for that tough neuroendocrine subtype?
Well, they summarize findings from several trials looking at combination therapies for neuroendocrine prostate cancer. Chemotherapy plus androgen deprivation therapy often forms the backbone that other agents are added to.
Okay. Any surprises?
One interesting point was about immunotherapy, specifically drugs targeting pathways called PD-1 and PD-L1. They haven't shown the same level of success in neuroendocrine prostate cancer as they have in some other cancers.
Huh. Why might that be?
The review suggests neuroendocrine prostate cancer might be what's called immune cold, meaning the tumor environment doesn't easily attract the immune cells that these drugs rely on. It leads the researchers to question if resources might be better focused elsewhere for the specific subtype, at least for now.
That's a really practical consideration. What about other targeted drugs they looked at?
They discussed a drug called cabozantinib. Results in broader castration-resistant prostate cancer were a bit disappointing in one major trial, though maybe some slight benefit elsewhere. There's some early lab data suggesting it might work in neuroendocrine prostate cancer, but likely only if specific molecular markers are present. So it really highlights the need for biomarkers to select patients.
Biomarker-driven therapy.
Exactly. They also mentioned what they called modest but encouraging results with something called revalpatuzumab tesirine. It's an antibody-drug conjugate targeting a protein called DLL3. Needs more research on dosing and combinations, but some potential there.
Was there anything that looked particularly promising in the review?
Yes, they singled out a drug called alisertib. It inhibits something called aurora kinase A. The review described its results as the most promising among the trials they analyzed, showing the longest period before the cancer progressed. Some patients had really remarkable responses.
That sounds hopeful.
It is, but they also stress we need more data to figure out why responses vary so much and to find reliable biomarkers to predict who will benefit most. And a final point was the lack of later-stage Phase 4 trials looking at long-term outcomes specifically for neuroendocrine prostate cancer. More research is definitely needed there.
And the review kept coming back to biomarkers, didn't it? Why are they seen as so vital?
Absolutely critical. The review really hammers home that we need better biomarkers for, well, everything. Earlier diagnosis, predicting how aggressive a cancer will be, and most importantly, guiding treatment choices, true personalized medicine.
Like using PSA or...
PSA is one, the androgen receptor status is another. They also mention looking for mutations in DNA repair genes, like the BRCA genes, which can predict response to PRRP inhibitors. But it's challenging because tumors can be really diverse, even within one person. That's tumor heterogeneity. Makes it hard to rely on a single biomarker sometimes.
And for neuroendocrine prostate cancer specifically.
A key point there is that many current treatments are actually borrowed from research on other neuroendocrine cancers, like small cell lung cancer. There's a real lack of therapies designed specifically for the unique biology of prostate cancer that either starts as neuroendocrine or transforms into it.
We don't even know how to stop that transformation.
Very limited understanding there. The review mentions some promising early preclinical work with PRP inhibitors and some other drug classes, but we're far from having ways to prevent it. Fundamentally, we need a much deeper grasp of the molecular pathways that drive both types of neuroendocrine prostate cancer to find truly effective targets. They briefly mention things like long non-coding RNA and microRNA interactions as areas needing exploration.
Wow, this has been incredibly comprehensive, really diving deep into metastatic prostate cancer. If you had to boil it down, what's the main takeaway for our listeners?
I think the key message is that advanced prostate cancer, especially aggressive forms like the neuroendocrine type, is still a really significant challenge. But there's a tremendous amount of research happening, leading to a much better understanding than we had even a few years ago. Cases like President Biden's are stark reminders of how common it is and why awareness and where appropriate screening are important. The science underscores the complexity, but also the ongoing effort to find smarter, more targeted ways to fight this disease.
Right. So maybe a final thought for you, the listener, to ponder. Given all this complexity, especially in treating metastatic and neuroendocrine prostate cancer, what kind of fundamental changes in how we think about cancer biology, how we approach treatment development, might actually be needed to get us to truly personalized, maybe even curative therapies down the road? Something to think about. We definitely encourage you to keep exploring the latest research and, crucially, to have those informed conversations with your own doctors about screening, any symptoms or any concerns you might have.
Thanks for tuning in to the Health Headliner podcast by To Digital. Like and subscribe for more health news and breakthroughs. Stay healthy and informed. See you next time.